Welcome to our live stream spine surgery at Deuk Spine Institute. The date is August 22nd, 2023. Our patient travels here to Melbourne, Florida from Niagara Falls. Which side? US side or Canadian side? US side. There we go. Patient's from Niagara Falls. And he has two large disc herniations, C4-5, C5-6. You can see from the x-ray there's degenerative disc disease, spondylosis, disc collapse, retrolisthesis, bone spurs, herniated disc, stenosis, radiculopathy, all that jazz. And in the end, it takes one surgery to fix it all. And that's the Deuk laser disc repair. So we're going to get started. I've already got access to the disc. And we've lost half of a drop of blood, not even a full drop. So far, half a drop. Shot? All right, you can see the needle is in 2, 3, 4, 5, 6. Everyone agree? Yes? All right, we're going to do our injection of dye. Shot? And there you see it. All right, very good. So the dye has actually left the disc space, gone out the front. I'll do a little more. Shot? All right. Jordan, show us on the x-ray there with an arrow where the herniation is. You all see the herniation? There it is. Show them, put the arrow right in the middle of the herniation. Right there. Perfect. We're going to go get that herniation out with the laser. Okay? We're going to do it without losing blood. We're going to do it without creating scar tissue. We're going to do it without fusing or metal or artificial disc, without biologics, without anything. Just natural. That's the way the patient wants it, and that's the way we give it with the Deuk laser disc repair. There we go. You guys see the half a drop of blood? How many drops of blood does it take to make 1 milliliter, 1 cc? Anybody know? 20. 20 drops per cc. 20. 20 is the magic number. We're not going to lose even 1 milliliter of blood. Incision. This is a 4 millimeter incision, folks. Look at that. The whole surgery will be done through that little incision. Why? Because the Koreans taught me how to do this. They taught me how to go endoscopically into the disc, go to the back of the disc where the herniation is, and just take the herniation out. Why do we have to take the whole disc out? We don't. There's nothing wrong with his disc, or anyone else's for that matter. The disc may be degenerated. It's okay. That's not the problem. The problem is the annular tear and the herniation, pressing on the nerve or spinal cord. And we can fix all of that without open surgery. That's done endoscopically. Now you may be watching this surgery saying, but it's so new, Dr. Deuk. No, it's not. We've been doing this for 17 years here. And the Koreans were doing it 3 years before us. I had to learn it from them. AP? There's your drop of blood. I think we've got a full drop at this point. How's it going on the live stream, Sanjay?
It's good, doctor.
Perfect. So you can see the tip of the dilator. Show us. Jordan, the tip of the dilator. Sanjay, you see the x-ray. Show us the x-ray. The arrow is pointing to the tip of my dilator at the front of the disc. It's in the dead center of the spine.
Yes,
dead
doctor.
center. It's perfect.
Yes.
That's what you want to see. Lateral. I'm going to advance my dilator into the disc. I do this by just twisting and pushing down gently. And by doing that, the dilator enters the disc by spreading the fibers of the anterior longitudinal ligament and annulus fibrosus. Dr. Burndes will give me a little inline traction, and I will get to the back of the disc at 5-6. 2, 3, 4, 5, 6. Shot. We are now at the back of the disc at 5-6. And I'm going to now place my tube and my fluid adapter. Oh, by the way, for those of you who have never seen the surgery, the whole surgery is done through this little tube. Incredible. Why is that? Because the disc itself is pretty small in the cervical spine. It's not big. It's small. And the tube is big enough to get to the back of the disc where I will be able to remove the herniation. At this point, I'm going to ask my team to give me some traction on the patient's neck and arms. So we're going to spread the disc space open just a little bit so that I can deliver the tube to the back of the disc. Shot. Guys ready? Yep. In line and go. It's moving. Shot. Nicely done. Shot. Nicely done. Just a few more seconds. Shot. Nicely done. And deliver. A little bit more. Bang. We're there. We're there. So now I have delivered the tube. Show us, Jordan. You see the tube is right there at the back of the disc. And I'm going to be able to take this herniation out through the tube. And that's what we're here to do. So far, we've lost 1 drop of blood. And I don't expect to lose more than 20 drops of blood, the whole surgery. All right, everyone ready? You know what I was just thinking? This is a really good surgery for Jehovah's Witnesses. Well, Jehovah's Witnesses, they don't want to lose blood, and we don't need to lose blood because we're not doing open surgery. There's the herniation right there. We're looking at it. It's literally in front of us. See that, Sanjay?
Yes, Dr. Deuk.
Sanjay, let's show our audience, how does disc herniation cause so much pain? We have a video. Let's share that with them.
Copy that.
Welcome back. So this is how the disc herniation causes so much pain. It has to do with the annular tear and inflammation within the annular tear. All right. I was just commenting to Luis on a patient that I just saw in clinic. And I saw this patient. He came in with a cane. He's a young man, very thin, good shape. And he came to me a few weeks ago, and he's already had a fusion done by another doctor. And he's telling me he's having horrible pain, and he's pointing above at the top of his neck. And I said, I think that's facet pain. So I asked him to go and get a facet joint injection as a diagnostic with Dr. Patel. And he said, oh, I already did that with another doctor. And I said, yeah, that's okay. I don't really care about the other doctor, because a lot of doctors don't do it right. They do the wrong type of treatment. And if you had it done wrong by the other doctor, well, and we believe that doctor's result, then you could be misdiagnosed, because we need the truth. We need to know if it's your facets. I explained that to him last time. I spent a lot of my time explaining to the patient why other doctors' diagnostic tests are not accepted here, because we don't trust their technique. And if you're going to trust those other doctors, well, why don't you just trust them to treat you? I mean, if you trust their diagnostic ability, trust their treatment ability. Don't come here. So the fact of the matter is, being as busy as I am, I don't have a lot of time for people who come here and then don't do what I ask them to do, basically. And so I was very short with him. And of course, he's upset, and he left. I gave him a refund. I basically said, don't let the door hit you on the way out. Okay? Of course, I didn't say that, but that's what I'm thinking. I said, I just can't help you. These patients, they come in here and they want to challenge me. And what they don't understand is that they're in no position to challenge someone like me, who, with all the years of experience that I have, that I've worked so hard to gather, and all the treatments I've done that work on patients. You can't come off the street and start challenging me. It's okay if you don't do what I ask you to do. It's okay if you don't treat with me. It's fine. But don't come in and waste my time trying to have a philosophical discussion after especially after I've already done that. So I told them, listen, I'm here to fix people, not to have discussions with people. I'm not a psychiatrist. Okay, that's one of my favorite lines. I'm not a psychiatrist. I can't talk your disease away. You know, your problem requires a physical treatment, and I can give you that treatment, but I can't talk it away. And some patients just want to come here and talk. And the reason I'm telling you all this is, if you're thinking about coming here and talking, don't bother, because I'm not going to sit there and talk to you for an hour. Okay, this is very disrespectful of people to think they can come here and monopolize an hour of my time when I'm trying to help people get better. The only way I help people get better is by doing treatments, the right treatment. So the problem is, a lot of people out there have pain for years, they're suffering. And, you know, they've been pushed around by the system, and, you know, the only thing they've ever gotten that's made them feel good is talk. And I'm not the guy to talk to you. So just keep that in mind when you want to come to Deuk Spine to get fixed. Don't plan on coming and having a conversation with me for an hour, unless you're buying me lunch. Just kidding. But in all seriousness, talk is cheap. Action is what matters, especially when it comes to fixing back and neck pain. All right, Sanjay, any questions?
No questions.
Good. By the way, you're welcome to ask us questions. We're here to answer them for you. We like answering questions. So we're at the back of this disc. You can see the bone spurs back here. There's a lot of them. And I'm using the laser, and these are all pieces of herniation. You see them, these white things? Literally, they're slipping out from around the tube. And normally I'll float them up. But when they're too big, I can't just float them up. I gotta laser them and cut them down in little pieces. How's our irrigation? Good? Very good. Thank you. All right. I don't mean to sound callous to you all. I'm not callous. It's just, unfortunately, the only way I really help people is by making a diagnosis and then doing a treatment. And the treatments are what fix the people, but it has to be the right treatment. And if you don't have the right treatment, you're not going to fix the patient. So I really do spend a lot of time and effort, my team does, to get the diagnosis right first, and then based on that, we recommend a treatment. There's tremendous amount of scar tissue here from the herniation. It's obviously been here a long time. And I'm trying to remove the scar tissue. Notice how there's virtually no bleeding, which is very nice. This is a pretty much bloodless surgery. There's a few drops and that's it. There's another piece of herniation wiggling out. I'll have to cut it down with the laser so it's light enough it can float in the irrigation and come out. If you have questions, feel free to ask. I like answering questions. And once again, our patient has traveled here from far away, and we're here to fix his neck without doing a fusion. He didn't want a fusion. I don't blame him. I wouldn't want a fusion either. I'm going to switch sides. But I can tell you this is not soft disc herniation. This is very hard, almost calcified, a lot of calcified disc herniation, starting to calcify. You can see it. This is all calcifying scar tissue and disc herniation right here. Now the laser can make quick work of it, which is wonderful. The laser is the best tool in medicine for this application. A lot of people online are saying, oh, Dr. Deuk, laser surgery, why do you need it? All these surgeons are saying you don't need a laser. That's because those surgeons have never used a laser. A laser is the most precise tool in medicine, period, hands down. There's nothing more precise. All right? Precision is everything when you're dealing with the spinal cord and the nerves. We're literally on top of the spinal cord and nerves. So by having a precise system like a laser and an endoscope, just to give you an idea how precise I'm talking about, that laser fiber you're looking at, the glass, that's a fiber optic cable, okay? And it's transmitting laser energy, not light energy. And that laser energy is coming out that tip. And that tip, that glass tip, how big do you think that is? Does anybody know? Sanjay? I know my team knows.
Half mm?
Half a millimeter. Very good. Half a millimeter. That glass tip is half a millimeter, folks. Think about how small that is. And the energy coming out of that tip is laser energy, and it only goes half a millimeter down from the tip. So whatever the tip touches, half a millimeter past is all that it does. It only works at half a millimeter. Now you tell me what surgical instrument is as precise? Nothing. The surgeon could use a scalpel. Scalpel, you can't see the tip with your eyes. So you need endoscopic surgery to see the tip, less than half a millimeter. But here we could see the laser fiber, no problem. You could see half a millimeter, no problem. You can actually see a tenth of a millimeter if you pay close attention. I can. 1/10 of a millimeter is right there, what I just did right there. You see that? That's a tenth of a millimeter. So it's not possible to do that with ACDF, laminectomy, discectomy, open spine surgery. Not possible. Not possible at all. So when these surgeons are criticizing laser, they're actually afraid of this technology. It's like the people that used to make the SLR cameras. They were criticizing digital cameras. And now everybody has a digital camera. But the SLR people like Kodak, they were afraid of digital cameras because it's going to put them out of business. So why are these surgeons so afraid of laser? You know why. It's going to put them out of business. That's why. And they know it. So all they can do is try to bash and make fun, like a bully would. Okay? Not a Bollywood, a bully would. Did you laugh, Sanjay?
Yes, yes.
You don't think I know about Bollywood, do you?
I don't think so.
The question is, do you know about Bollywood?
It's on Netflix.
Yeah.
Of course.
For those of you who don't know, Bollywood is India's version of Hollywood. All right, making good progress. My feet are starting to feel a little wet. Any questions from our audience?
No questions.
All right. Now, Sanjay, are we going to get 100% of this disc herniation out?
No.
No. You're right. You've been paying attention. That's right. No surgeon can ever get 100%. No surgeon. Only God can get 100%.
Most of them don't even try. They just use it.
Yeah, most surgeons don't even take the disc herniation out. They just fuse it. It's funny you say that because not many people know that. But that is absolutely true, especially the orthopedic surgeons. I've noticed the orthopedic surgeons don't even take the herniation out. They just fuse. Had a good talk with Santiago. Did he tell you? I was talking to Luis. Did he tell you?
No, I didn't talk to him back after.
He's doing great.
Yeah, he's doing great.
He wants to come.
Oh, he said that?
Mm-hmm. Yep. He's gonna come. I'm sure of it. But he wants to come to Orlando, not Melbourne.
Yeah, I mentioned to him.
Mm-hmm. Yeah, he wants to come to Orlando. That's great news. We couldn't have a finer doctor, huh? Thank you. I asked him, how much pain management procedures are you doing? He said he's not.
Yeah, he's not.
Because he's got so much anesthesia he has to do. So I think he misses pain management. I really do. It's sad when you do a whole fellowship in pain management, you don't even use it. Man, this is just like concrete right here. This surgery would have been really challenging for any surgeon to do with open surgery because this is like concrete. Thank God we have the laser. The laser makes it feasible to remove all this calcium, all this scar tissue, massive amounts. Look at all this. It's incredible. It's going very well for this patient, by the way. Questions from the audience?
No questions.
No question. All right. Have you played our videos?
Yes. One of them left out.
Let's do the Deuk laser disc repair video.
Copy that. Playing educational video in 3, 2, 1.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. You can see how the Deuk laser disc repair works in that video. All of this is scar tissue here, all of it. See how dense it is, this white stuff? Massive scar tissue, massive. I'm just about done. I've gotten as much as I can. Remember, no surgeon can get 100%. So don't expect it. But we get as much as we can safely. And that was the last piece that was in the framing. You guys see it pop out? That was pretty cool, huh, Sanjay?
Yes, we do.
It was sitting right on his nerve, crushing the nerve. See how I floated out by using the hydrostatic pressure of the irrigation? Just want to make one more look. I don't see anything more. Looks really good. Gonna go check the other side, and then we'll be done. And we're gonna go move to the next disc. Now, remember I told you I learned endoscopic from the Koreans. Dr. Sang-Ho Lee, okay? Dr. Gun Choi. These guys were top. They're the first in the world to do this surgery. Cervical, anterior cervical, transdiscal endoscopic. They taught me 17 years ago how to do it, but I'm the first to bring the laser and do the annular debridement. That's what makes Deuk laser disc repair different. I also keep my patients asleep. They had their patients awake, moving around, okay? I don't know why. They felt that that was better. I don't agree. I think it's worse. That said, these doctors that I learned this treatment from, these Koreans, they were the top. And I think they're all retired now. I was younger, much younger than them. So I had the benefit of learning the technique and then taking it and applying it. Okay? So currently I'm the only one in the United States and probably the world doing anterior cervical endoscopic transdiscal laser debridement of the annular tear and herniation. You're not going to find this surgery too many other places. We're the first to publish it, the first to do it. We named it. All right, we're done with this disc. But the other thing I did for the first time was, is this dye or is this iodine? Iodine. We're putting some iodine dye to clean out the area that we just operated on. We're also the first to do a multi-level. The Koreans never did multi-level. In other words, the Koreans would always do one disc at a time, but I realized very quickly that patients had more than one disc. They actually had 2 or 3 discs. Suction. They were symptomatic. And so if you really want to, come on, Luis. If you really want to help these people, you got to do more than one disc at a time. All right. So far, we've lost about a cc of blood. That should never be pointing at me. Figure out the best way and keep it that way. Let's go, Jordan. So the ability to do more than one disc in a surgery, that was developed at Deuk Spine by myself. It was never taught to me by the Koreans. We had to develop that technology here at Deuk Spine Institute over the years. I need a Raytech shot. Shot. All right, so we are now, I've taken the tube out of the disc, shot, and I'm going to start to move this dilator up to the next disc, which is the 4-5. Everyone agree 4-5 is next? All right, here we go. Shot, shot, shot. Now to do this, I have to pop out of the disc space, which I just did, and I have to settle back on top of the spine, which I just did. AP, I want to make sure now that I'm in the middle of the spine. Let me know when you're ready.
Ready.
Shot. All right, so we're still in the middle, which is good. Now go back to a lateral. I'm going to now move the tip up to the next disc. Shot. Here we go. And to do this, you got to stay on the spine, which I just did. Shot. Perfect. AP. Now I want to check again. Am I really in the middle still? Am I still in the middle? Hold. All right, good. Oh, you got my hand. Shot. All right, so it's about the middle. I want to go a little bit, a tiny bit to my right, his left. Shot. Okay, let's go back to a lateral. Quick. Shot. Perfect. Sorry, hammer. Now that we're in the middle of the next disc, I can advance my dilator into the disc space. Now as I do this, I'm going to get some disc material stuck inside the tube. Inside the tip of the dilator there's a little hole, and I want to clean that out. Shot before I do my discogram. Shot. All right, good. Now we're going to do a discogram. So the slide from one disc to the next is called the Deuk spine slide. You can see the dye there. A little bit has come out. That's better. Now I'm going to advance the dilator a little more. Inline traction, please. Shot. His anatomy is literally limiting my ability to place the tube properly because it's forcing the tube to point towards the head, which we don't want, but that's just the way God made them. So these are some of the challenges a surgeon has to overcome as you're doing these types of surgery. Shot is that you've got to learn how to optimize each situation and get the most out of it. Because if you don't, you're going to end up having problems during the surgery. So you got to be good at solving problems. Shot, inline traction, and here we go. Luis, your job is to keep an eye on that dilator tip. Let's go, everybody, a little more. Shot. Just about there. Oh yeah, that felt good. That felt really good. Shot. That's perfect. That's as good as we're going to get it. It's like not perfect, but it's as good as we can make it here, which is perfect for what we've got. Any questions, Sanjay?
Yes, we have a question from Neil Othman on Facebook.
Sure.
How can we tell when the herniation is increasing?
How can you tell a herniation is increasing?
Yes, that's
Well,
correct.
there's symptoms like increasing neck pain, increasing headaches, increasing arm symptoms if it's in the neck, increasing back pain, increasing leg or arm symptoms, like I said. And then, of course, you can get an MRI scan and see the herniation is getting bigger. That's how you do it. Symptom-wise and structurally, you can get an MRI or a CAT scan, preferably an MRI, and you can actually see the herniation getting larger. Okay, we're at the back of the disc at number 4-5, and I'm using the laser, and look at all the calcium. Just tremendous amount of bone spurs here. All of this is calcium, bone spur. And you can see the laser removing it carefully. I've got to be careful when I do this. That's a bone spur. All right, great questions. We're going to be done in 15 minutes max, Dr. B. So I'm going to tell my anesthesiologist we're going to be done very soon. So he can start making an adjustment on the patient's anesthesia. Yeah, it's really incredible. The disc has completely forced our scope upward. And what you're seeing is a bone spur off the bottom of C4. I see these all the time when I do surgery. Very common bone spur to see. And I usually remove them when I do fusions. So, but that's if you're a surgeon and you're doing ACDF a lot, like I used to do 1,000 of them, you know this bone spur. You see it all the time. And you see how the laser removes it easily. Okay, let's turn around and go the other way. Any more questions, Sanjay?
No questions.
All right. Once again, this patient's herniation is unusual. It's extremely calcified, a lot of bone spur, and makes it very, very difficult. His anatomy has made it so hard to get to the herniation. You see, the herniation is really here. But we've been forced up into this bone spur, which is fine. We'll just have to remove it. Okay? You can see how easy it is for the laser to remove bone spurs. Sanjay, you see that? A lot of people ask, can the laser remove bone spurs?
Yes, Dr. Deuk.
You're going to see that, okay?
Yes.
And the answer is yes, we can. Very easy. Removing a bone spur with a laser is like melting an ice cube with a hairdryer. Very easy, very easy. Berndes, yeah, 5 minutes. Man, these flexible scopes are amazing, Luis. You know? If this was a rod lens scope, we would be in trouble. I'd be breaking the scope almost every surgery. But the flexible scope really is very useful for these abnormally shaped areas. And when I say flexible, it's not the kind of flexible scope some people might be thinking about. It's actually it's a rigid scope. Yeah. But I'm forcing it to be flexible, which is not good for me because it's going to break the scope eventually, and I'm going to have to spend more money fixing it. But I always like to do what's best for the patient. After all, what's the point of having a scope if you're not going to fix the patient the right way? That's a bone spur right there. Just melted it away. Oh yeah, look at that herniation there. It wants to fight me. Okay, come fight. The reason these herniations are not staining blue like we like them to is because they're so scarred up, and a scarred herniation doesn't stain blue. Only a fresh, I mean a few years old herniation will stain blue. Most of these herniations here are not fresh. They're old and extremely scarred up. very hard to remove. This is all scar tissue. An ocean of scar tissue. I'm just peeling some of it away to see if there's a herniation underneath it. Okay? I'm not as interested in the scar tissue as I am in the herniations. The scar tissue really doesn't push on the spinal cord or nerves, and it doesn't cause problems, but the herniations do. You can see the herniations floating around like that right there, okay? So I got to try to get rid of it. But on a scale of 1 to 10, this is a 10. This surgery is definitely a 10. This is as hard as it gets. And I'll tell you why. It's simple. This patient's disc is extremely scarred. This is not simple herniation. This is extreme inflammation over years and scarring. And the herniations are calcifying. They're turning into bone. And so look at this. I mean, you would not be able to get rid of this with normal surgery. With an ACDF, it would be almost impossible. But I'm using the laser to remove all this material that you couldn't remove otherwise. Okay? I've done 1,000 ACDFs in my career, and artificial discs. ACDF/artificial disc. And I've seen this area 1,000, actually about 3,000 times. No, more than that. About 5,000 times. If you add up my ACDFs plus laser surgeries, I've been in this area because the average patient has 2 herniated discs. I've been in this area thousands of, almost 5,000 times basically. And this, in my opinion, is one of the worst I've ever seen. Look at that. That is not a nice herniation. Nice herniations are easy to remove. This thing is a beast. This is a level 9 to 10 in terms of difficulty. And I'm doing my best. You see the fibers of the posterior longitudinal ligament? Under all the scar tissue right there? Holy mackerel. 5 minutes. So, these patients, they all have pain after surgery in their neck. Everybody has neck pain for the first night usually, and then it gets better and goes away. He's definitely going to have pain because I am manipulating his spine quite a bit. Like right now, I'm really fighting. Oh, there's a piece of herniation right there. See that? Oh yeah, here it comes.
Yes.
Oh, don't go back down. I've got my nurses on the irrigation. The irrigation, I can't emphasize how important it is. It's so important to get the irrigation right. Look at all these pieces of herniation here. The irrigation is so important to get these things out. Otherwise, let me grab it. Otherwise, you're going to have a hard time getting all these pieces out. So you rely on the hydrostatic pressure and fluid dynamic movement to get all these things out. These are the things I don't normally talk about during surgery. But they're important to talk about.
We have a question from James on YouTube.
Sure.
He says, hello Dr. Deuk.
Hi.
I have a question.
Yes.
If you have fractures in your vertebrae and you opt for the kyphoplasty surgery, are the adjacent vertebrae below and above subject to adjacent failure?
I really didn't understand the question.
if you have fractures in your vertebrae
Yes.
and you opt for the
Kyphoplasty.
kyphoplasty surgery,
I got that part.
are the adjacent vertebrae below
Ah.
and above subject to adjacent failure?
I see. If you have a kyphoplasty, are the vertebrae above and below subjective to adjacent failure? No, because you're not operating on a joint. You're operating on the bone. All right, that's as good as I can do it. I cannot get any more.
Nice on, please. Thank you.
And I've gotten 60%. 60% is the magic number. If you get 60% of the herniation, you're going to fix the patient's symptoms. No. All right, we're done. If you have questions, feel free to ask me. Do you know who is next?
No further questions?
Oh, nice.
No way. I thought you were really worried about that. Did you get it in? One of the nurses? Okay, we lost about 1.5 cc's of blood. That's around 30 drops. And I'm going to show you the incision. Did you say you have another question, Sanjay?
No further questions.
All right, very good. So I put a little bit of pressure because everybody has venous bleeding. Here's a marker, a tape measure. You guys can see, can you see this, Sanjay?
Yes, I do.
Mm-hmm. You see how small the incision is?
Yes.
It's 4 millimeters. And it's bloodless, except for 1.5 cc's. Great job, everybody. That was hard. That was really hard. But we did it. Let's go ahead and I'll come answer questions, okay? You can go to a testimonial.
Copy that. Playing testimonial in
I'm s-
3, 2,
Was mostly in the neck and shooting down my shoulder and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
Before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, 2 of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see
there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny. And here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday.
Highly suggest coming to me.
Awesome. All right, my friend. Congratulations.
Okay, we just finished up the Deuk laser disc repair cervical. This patient had 2 herniated discs, but they were far worse than a herniated disc. They were full of scar tissue and calcium, which most of you understand is a bone spur. And you saw the laser go into action with the bone spurs. It just cut them down. The problem for me for this one technically was getting to the back of the disc space parallel to the disc space. What does that mean? Well, you could see the herniation there, right? I want to go in like this, and I want to be perfectly parallel to the disc space. But what was happening was because he had some bone spur in the front that was pushing down on my tube, as I went in, it was pushing my tube like this. So as I went back, I was forced up to look at the top of the end plate, basically the end plate up here. I don't want that. So I was constantly having to fight to lift my hand and push my tube up so I could get to the herniation. I don't know, could you guys see that? Yeah. And it was really challenging. And I call it a level 10 because number 1, I had to fight the tube to get it to point the right direction at the back of the disc to see the herniation. Number 2, the herniation was extremely scarred. It must be about 30 years old, 40 years old. And it was just full of calcium, making it hard, thick, cumbersome, very difficult to work with. But in the end, I really feel like I was able to get about 60% of the herniation out of there. Now, people call me sometimes and say, hey, I got an MRI, I have bulging discs, I have degenerative discs and stuff after surgery. That's right. We're not going in and taking all your bulging discs out, all your herniation out. It's impossible. No doctor in the world can do that. Doesn't matter what surgery you get done. The purpose of surgery is not to make your spine look normal. Okay, that's something a lot of people just don't understand. The purpose of surgery is to make you functional by getting rid of your pain that's coming from your neck, that's in your spine. We want to eliminate that pain. We want to get rid of the pinched nerves that are causing numbness, tingling, and weakness in your hand. So unpinch the nerves, eliminate neck pain, and improve your range of motion. That's really the goals of surgery, and to do it all safely. So there's no complications, no downside, and minimize the risk and speed up the recovery. That's really the purpose of surgery. And that's what the Deuk laser disc repair does better than anything. All right, let's see what questions we have.
We have one question from James on YouTube. Does the fusion surgery has adjacent failures?
Does the fusion surgery have adjacent failures?
Yes.
Yes. Fusion surgery, when it's done, has a high chance of what's called adjacent disc disease or adjacent segment disease. And what that means is if you're doing a fusion of the spine, like here, you could see the cage and the disc, you could see the plate, then the disc above and the disc below will fail. Look at this right here. You see the failure of the ligament? Why is it failing? It's failing because when you put the metal plate on the spine for the fusion, you're cutting the ligament and now the ligament is loose. You see that? That's the anterior longitudinal ligament. So now, of course, the other disc is going to wear out. You're going to have to do another fusion. That's called adjacent segment disease. Any other questions?
I have a last question.
Yes.
So just like we witnessed during the surgery, is it that older herniations are hard to get rid of as compared to the newer ones?
So the question is, are older herniations harder to get rid of compared to the newer ones? The answer is yes, because they're more scarred and stuck down to the dura and spinal cord and nerves. It makes it a little harder, but the laser is amazing. It literally peels the herniation off, and it creates, with its pulsing activity, it creates a separation of the herniations and lets them separate and float up as soon as they're released from the scar tissue. The problem is all these herniated fragments are scarred. They're stuck in there. So I use the laser to hit the scar and clean the scar. That releases the herniations, and then the pulsing of the laser, the pulsing of the water from the laser pushes them up and out. So older ones are harder, definitely, to remove with the laser and the grabbers than the newer ones.
I think that's all the questions for this session.
I hope you enjoyed surgery. We lost only 1.5 milliliters of blood, 30 drops. It went very well. We fixed both discs. We had no complications. Patient was stable. He's being extubated now. Tube is being taken out. Our next patient, I'll just tell you, he's a double amputee. He's had both of his arms amputated off, and he has been suffering with back pain for years, and nobody has been able to help him. He lives with his wife. She stayed by his side. She's a dedicated friend and companion, and they found us on the internet, and he's here because he's in so much pain. He has been for years. He's got 2 or 3 disc herniations we're going to fix with the laser surgery in his lower back, and then he's got the facet joints on the left side, which we're going to fix. So for those of you who don't know, these are the facet joints here, and the discs are in the front. We're going to fix the discs. We're going to fix the facet joints with the Deuk plasma rhizotomy. So come back in about 30 minutes and enjoy the surgery. Thank you, Sanjay. I just want to applaud Sanjay. He's done an amazing job. And Henry is out in Orlando at our work comp meeting. And Henry is doing the talk with Dr. Francis Cheney on the Deuk plasma rhizotomy to all the adjusters. Have a great day.